We good to go? Good. Good afternoon and welcome to the Health and Government Operations Committee briefing. This is a virtual committee briefing, so I ask for your patience if we encounter any technical or streaming difficulties. This briefing is being streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted throughout this briefing. If you have a question after the presentation, please use the raise hand function, which is located either underneath the participant list on the right side of your screen or under the reactions bar at the bottom of the screen. I will call on delegates to ask questions. After we call your name, please wait a moment while Melissa unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each member of the panel. Also, please keep your questions shorter than the expected answer. Today, the Health and Government Operations Committee will receive a briefing from the Behavioral Health Systems Baltimore on the Greater Baltimore Regional Integrated Crisis Systems GBRICS Partnership. In the panel, we'll hear from Adrienne Bridenstine, the Vice President, Policy and Communications for Behavioral Health Systems Baltimore, Gail Kloss, a volunteer with NAMI, Howard County, Tiffany Calendar Eberling, that's not Eberling, Erbalding, I'm sorry, Program Director at the Horizons Foundation, and Nikki McCann, Vice President, Provider and Payer Transformation at the Johns Hopkins Health System. The presentation will be followed by a Q&A session. Please keep in mind this briefing is scheduled to conclude at 2 p.m. Ms. Bridenstine and the panel, if you will, when you're prepared, you may begin.
Thank you, Chairman, and thank you to members of the committee for allowing us this time to present to you today on the GBRICS partnership, which is a really exciting initiative. I know that there are some slide decks that you should have received, and I believe someone is going to be sharing those for us. Thank you, Melissa. But really quickly, I'll just briefly tell you what it is, but I want to turn it over to Gail Kloss and have her actually talk to you first. She's got a very powerful personal story to tell you. But the GBRICS partnership is intended to help expand and strengthen behavioral health crisis response services across Baltimore City, Baltimore County, Carroll County, and Howard County. We've been working on this at Behavioral Health System Baltimore with a number of partners for over a year, including 17 different hospitals and 4 local behavioral health authorities. And we've been able to do that with much of the support from many of the members on this committee today, which we are grateful for. We would not be at this point today if it weren't for the support that we've gotten from many of you. So I'm going to pause and just leave you with that very brief overview and turn it over to Gail, and then I'll explain more about what GBRICS is in a little bit.
That's a women's conference. Is that committee?
Melissa, could you mute the members who are members? Could you mute yourselves if you're not being recognized right now? Gail? You're muted, Gail. Okay, now we can hear you.
Thank you. Thank you very much. Good afternoon. My name is Gail Kloss, and my husband and I have been residents of Howard County for over 30 years. It's a pleasure to be here today and to share a bit about our family's history with the challenges of mental illness. There's a small wooden sign in the foyer of our home that one of the older kids gave us. It reads, "Remember, as far as anyone knows, we're a nice, normal family." At our house, this reminder is both helpful and hopeful, for in truth, our family of 7 has struggled long and hard to get to the semi-normal place where we are today. Dave and I are proud parents to a blended family of 2 homegrown and 3 heart-grown kids. One of the youngest children was born overseas very prematurely, under traumatic circumstances and with physical challenges that required him to undergo years of corrective surgery after joining our family. By age 4, this young son had also begun to show signs of emotional and social disability. Over the next 10 years, his condition worsened, his moods became erratic and explosive, and he acquired one diagnostic label after another. This son, now 23, is intellectually very bright, has proven to be an excellent writer, and is capable of great humor and caring. But for years, he has suffered from bipolar disorder, depression and anxiety, ADHD, reactive attachment disorder, and numerous other mental illnesses. He has been hospitalized more than 20 times during the last 6 years, hospitalizations which usually began with an emergency room visit. Through our employment with the Department of Defense, Dave and I have both benefited from access to affordable health insurance for our family. This insurance has helped in times of crisis by providing coverage for emergency mental health care, as well as for regular therapy visits. As residents of Howard County, we have also benefited from the free education and support groups offered through NAMI and from the supported housing provided to our son through the Humanum program. We are fortunate to have the resources of many local organizations which help families like ours who deal every day with the uncertainty of mental illness. Nevertheless, when a crisis situation has occurred, when we have needed immediate assessment for our son or assistance with a sudden escalation of volatile, unstable behavior, when furniture is being broken or holes punched in walls, or siblings frightened by angry shouting that can be heard out to the street, then we have frequently been at a loss as to which direction to turn for crisis intervention. Therefore, we are also parents who have lost count of the trips made to ERs and to walk-in trauma centers, who have waited many hours and often for days in hospital emergency rooms for mental health assessments, and who have had to call police to take our raging, out-of-control teenager from our home to the hospital. Although the officers have been trained to deal with mental health crisis situations, plastic handcuffs are still handcuffs, especially to a group of anxious siblings. We know from our personal experiences that handcuffs are not a solution for a mental health crisis. We believe that community-based behavioral health crisis services, meaning neither police nor hospitals, are what our community needs. The GBRICS partnership presents a great opportunity for more appropriate and timely care to those dealing with a challenging mental health episode. Often our efforts to get our son into a mental health hospital have been unsuccessful due to overcrowding, and he has had to be placed in hospital facilities that were not prepared to deal with his needs. GBRICS focuses on a system of expanded services in the community, services that would provide the right kind of care for individuals and families when they need it, a system based on a behavioral health crisis response rather than relying on emergency medical services. Based on our family's experience, this program represents a vital leap forward for everyone. Thank you for your time today, and from the Claus household to yours, best wishes for a healthy, happy New Year. Thank you.
Thank you.
Thanks, Gail.
Tiffany, gonna,
Oh, I'm going to chime in again. Melissa, if you
Okay.
can pull up my slides. Thank you. So as I mentioned earlier, the GBRICS partnership, next slide, is a partnership that we've been working on for over a year with many different partners. In summary, this partnership was developed in response to an RFP released by the HSCRC, or the Health Services Cost Review Commission, that came out January of last year. Their RFP focused on a couple of funding tracks, one of those being on behavioral health crisis response. They were looking for proposals that aligned with the nationally recognized Crisis Now model, which you'll hear a little bit more about from Tiffany in a bit. The proposals were intended to be 5-year grants and with a focus on sustainability. So Behavioral Health System Baltimore, who many of you I know us, but for those who don't, we are a nonprofit who serves as a local behavioral health authority in Baltimore City. We convened all of the partners across these jurisdictions, again, for over a year to work on developing a proposal in response to this RFP. We submitted it in July of last year, and in November, the HSCRC voted for all funding awards and voted to fully fund ours. Next slide. In brief, it will invest $45 million over 5 years in behavioral health crisis response infrastructure and the expansion of certain services across those 4 jurisdictions: Baltimore City, Baltimore County, Carroll County, and Howard County. As I mentioned, it was developed with the hospitals in all these jurisdictions and the local behavioral health authorities, but also peers, people with lived experience provided input, behavioral health providers themselves, faith-based institutions, and a variety of other local leaders across those 4 jurisdictions. The proposal itself was supported by 38 different collaborators and 25 letters of support from elected officials. Again, thank you for those of you on this committee that supported it. Next slide. In a nutshell, the proposal includes 5 key elements. What we want to see happen and what the HGO wants to see happen over the next 5 years is an overall reduction in unnecessary ED use and police interaction for people with behavioral health crisis. The thinking behind this is if we have more robust behavioral health crisis services at the community level, that we will be able to see a reduction in ED use and police interaction. So our partnership includes a couple of key elements. The first would be standing up a care traffic control system. And this is really looking at investing at that infrastructure investment. Care traffic control is a very similar concept to air traffic control. Just as you need to know where all the planes are in the air and land them safely, the same concept applies to our behavioral health crisis response system. We need to know where people are and how where our services are being deployed to safely stabilize them, and then where people get connected up to care and ensure that they get connected up to care after they're stabilized. So this care traffic control infrastructure would be software technology that would give us the ability to track referrals in real time. It would include a bed registry. It would allow us to coordinate the dispatch of mobile crisis teams across the region. Big data would come out of this, data that we currently track, but then additional data that we don't track that would help us have a better understanding of what the overall need is. And then it would create a regional hotline that would be supported on the back end by this system. The second component would be expanding mobile crisis teams. We learned in doing the development of this proposal that the mobile crisis teams across the 4 jurisdictions vary in terms of their capacity and in terms of their staffing. We would look to make sure that there's 24/7 mobile crisis teams across the region. So some jurisdictions do not have that, for example. Set regional standards so that all programs are deploying the same way, for example, and make sure that what the standards we do set are aligned with national best practices, such as SAMHSA's guidelines for crisis services best practices. The third component would be looking at using our existing behavioral health system infrastructure, specifically by working with outpatient behavioral health clinics like outpatient mental health clinics or opioid treatment programs, to work with them to offer same-day access to services. So that would be virtual or walk-in appointments, unscheduled appointments for people who are in crisis to help them address their immediate needs. The fourth component is looking at community engagement and outreach. So this is really to help support overall culture change and system change. We recognize that all too often we are way too conditioned to calling 911 or using the emergency department for care. And that is a bigger system and culture change that we need to be supporting at the same time that we're making these investments in our expanding services and the infrastructure. So we've built in community outreach and engagement to help support that culture change and having people to realize that there are alternatives to calling 911 or BED in the community to get care, behavioral health crisis care. And then the last component would be standing up a multi-stakeholder accountability structure to really help drive the overall project and support shared accountability. So we will be in the process of creating a GBRICS council, which would be a 21-member council of a variety of different stakeholders that would really help guide the overall implementation of the project, but also have a laser focus on the sustainability of the project. So to look and focus on ensure that what we stand up over these 5 years can be sustained when the grant is ended. Next slide. So at a very high level, this is what the implementation timeline looks for the GBRICS partnership. Year 1 through 3 is heavily focused on building out that infrastructure, with years 4 and 5 is when we're hoping to start to see that impact, in particular on those scale targets I mentioned earlier, which is a reduction in ED use for people with behavioral health conditions. Next slide. So sustainability of this project will be very important, and Nikki's going to talk about this in more detail in a little bit, but overall what we're looking to sustain the project, we're looking to do 2 big things. Changing the way things are done, so doing that through creating these regional standards and really focus on increasing the awareness about behavioral health system services so that we can support that culture change. But then the second piece being advocacy and policy reform at the state level. For example, looking to see if there are changes in policy we need to make, looking to see if there are, if we could seek coverage and reimbursement for certain crisis services that are not currently covered by insurance, such as mobile crisis. Next slide. Oh, and so I'm done. So at this point, I'm going to turn it over to Tiffany. Thank you.
Actually, Melissa, in the interest of time, I may say I will just speak if that's okay, and others, the slides were made available, right? Great. Okay. So then I'll just go ahead and speak, and that way Nikki can have a chance to jump in as well. I'm Tiffany Callender-Erbelding, a Senior Program Director with the Horizon Foundation. Thank you for having us. Thank you, Chairman Pendergrass, and also Delegate Hill for being our Howard County representatives. Also, Delegate Pena Melnick for your support as well. We're very appreciative to you all for your partnership. I'm going to share a little bit just about the Crisis Now model. Again, I'll speak pretty quickly. Adrian did cover things very well. And I'll talk a little bit about the role of philanthropy and how the foundation has been able to partner with GBRICS. As Adrian mentioned, the HSCRC goal was to really see this Crisis Now model implemented in the community. And Crisis Now model is really a framework. It's really a best practice for what communities need to be considering and looking to implement if they're trying to provide comprehensive emergency crisis services. As we heard from Gail as well, there's opportunity definitely in our region and our community to shore up our existing services. Three key components there are, as Adrian mentioned, one is this idea of these care traffic control centers, these hubs essentially that are that first line of defense, that first call that someone may make if they're in a space of crisis and need. And those centers are actually very well equipped with a dashboard where they can see regionally the care across the community. They can see utilization, where beds are available, how long individuals may be waiting for care. It really is this idea of a data care traffic control call center hub. That's the first component of this idea of the Crisis Now model. That second component are those mobile crisis teams that Adrian mentioned and that GBRICS is really looking to, again, expand and ensure they're 24/7. Mobile crisis teams are able to provide in the community crisis response, which, as Gail mentioned, a lot of times our families are winding up in the emergency department, and we really want to be able to provide and meet them kind of in the community. So having mobile crisis teams operating 24 hours, 7 days a week is really key to this idea of being a comprehensive Crisis Now community. And the last component of the model are these crisis stabilization centers, which really are intended to be short-term subacute levels of care, where someone that might need some support but maybe doesn't need inpatient treatment can receive some short-term care. So if you think about those three components of the Crisis Now model, Adrian talked a bit about GBRICS and what it's going to implement to really shore up regionally our crisis services. The last thing I'll say is the foundation, behavioral health, health and wellness are our mission at the Horizon Foundation in Howard County. We were very grateful to partner on this. We were able to provide, our role has really been to seed innovation and provide some front-end funding to not only increase staff capacity to respond to the HSCRC proposal, but to also stand up some of the staff needs, as Adrian mentioned, the policy work group, bringing on a policy director. So we've really been able to kind of front-end partner. We also were able to take a delegation of individuals out to see the Crisis Now model in action in Arizona back in 2019. So in July, we took about a dozen folks, representatives from government, Baltimore City, Adrian was with us, Department of Health, crisis providers, to actually see this model in action and how we might be able to bring it back to our region. So moving forward, again, the foundation's really been able to partner on the seeding beginning process here, being able to partner in thinking as well. We want to continue to help evolve the program, see if there's ways to evolve crisis services in the community, make them even better, and also look, as Adrian touched on, and I know Nikki will touch on, at opportunities for sustainability long term. So with that, I will pause and hand off to Nikki.
Great. Thank you, Tiffany. And thank you so much for the opportunity to be here. I'm going to speak just a little bit about potential opportunities for sustainability. Before I get into that, one thing I do want to highlight is that the hospitals, the 17 partnering hospitals, are the recipients of this grant, but there will not be a single dollar retained by any hospital. All of this $45 million in funding will go out into community-based care, because from the hospital perspective, we believe that that's where the support is needed. So speaking to the opportunities related to sustainability, I think an important statistic to help frame this is that 60% of patients brought into a hospital emergency department under emergency petition, this is where individuals are brought in by the police, 60% of those individuals are discharged. They're discharged because they do not need an inpatient level of care. That doesn't mean that these individuals aren't experiencing a crisis and don't desperately need services. They just don't need a hospital inpatient bed. And because of the lack of community-based services, police and hospital emergency departments are often the only alternative. So when we're thinking about where's the opportunity, that's a big chunk of opportunity to try and get that 60% of those individuals with access to community-based care through the mobile crisis teams, through the hotline, through same-day services. As Adrian and Tiffany had mentioned, that this model is an evidence-based model. This is a model that has been proven to be successful elsewhere. You could look at Arizona and Georgia, other local jurisdictions where this has been a successful model. And if I could just share sort of a few data points from their experience. In Maricopa County in Arizona, this model was the equivalent of basically 37 full-time police officers. These are individuals who can now respond to other public safety issues because they're no longer responding to a mental health crisis. There was $37 million in cost avoidance at hospitals because you no longer have these individuals coming to the emergency department. And then there was $260 million in costs avoided to the state. About 70% of individuals accessing and utilizing the public mental health crisis system and brought into hospital emergency departments are Medicaid. And if you look at the cost of coming into a hospital emergency department, an evaluation, the time spent there, that could be $1,400 a visit, much cheaper than what a mobile crisis team might be. So thinking about sustainability, that was $260 million in savings to the state. So those are the opportunities for sustainability. We, the hospitals, know that if this is a successful model, then we have a role in ongoing sustainability. But this model, which we hope will prove to be successful and be taken statewide, cannot be sustained with hospital funding alone. We need to partner with state and local government. We need to partner with our elected officials on policy changes, Medicaid reimbursement, commercial payer reimbursement for some of these services. So that's where we see the greatest opportunity for sustainability. And before I conclude, I want to say that the fact that the 17 hospitals continued to move forward with this application in light of COVID, I think speaks to how much we think these services are needed. COVID happened while we were in the midst of this application process, but we still move this forward with partners like the Horizon Foundation and Behavioral Health Systems Baltimore. It has been a real honor to be part of this project. And I think we know that COVID has only highlighted the need for these services. And so we really look forward to working with you in the future and ensuring that this is a success. We will never have this level of funding, $45 million to invest in behavioral health services. We likely won't have this opportunity again, so we want to make sure we get it right. So thank you, and happy to answer any questions.
Good, thank you. Whoops. Well, there are those technical difficulties I warned us about. Thank you for that briefing. It was very helpful, and I'm very optimistic that this is going to be a real asset for the communities that are involved right now, but even longer term, the state, and also the impact that this is going to have on our waiver, because that's really going to help with the federal waiver. So good work to all of you. I see one hand, Delegate Cullison.
Thank you, Madam Chair. And I also want to say thank you for this presentation. I'm really excited about the program. I wondered if you had already begun to intersect with some of the state agencies around that serve around mental and behavioral health to see how ultimately, hopefully, a program like this might dovetail with the work and intersect with the work they're doing in a positive way.
Adrian may want to add more, but we have been working closely with Maryland Medicaid and the Behavioral Health Administration, as well as the local government, each local government, and we will make sure that local governments are represented on our advisory council, as is Medicaid and the Behavioral Health Administration, and they've been great partners to date. Very enthusiastic about this.
Great, thank you.
Next, I see Delegate Lewis and then Delegate Johnson.
Thank you, Madam Chair, and thank you, Adrian and Nikki and Tiffany, for your presentation. I'm curious, I'm excited to hear about this program. It sounds very promising. I'm curious to know whether this program serves or aligns rather with the mission of the Community Benefits Program, which is part of HSCRC's essentially oversight of hospital performance. Can anyone help me understand the connection, if there is any?
Delegate Lewis, I can take that question in that I can tell you, specifically speaking to Baltimore City and Howard County, where Johns Hopkins hospitals are, is that that everybody's community benefit report lists mental health and substance use in their top 3 needs. So when the community is asked through a community health needs assessment, what is your priority? What do you want from the hospitals? What do you need? Mental health and substance use are always at the top of the list. And in fact, in the years that we've been doing the community health needs assessment, it is only getting higher. So it used to be number 3 on the list, and now it's number 1 and 2, depending on each jurisdiction, each community. So that's where there's the opportunity for alignment, is that we are meeting the need that has been identified by our community.
Thank you. Thank you, Madam Chair.
Delegate Johnson.
Thank you, Madam Chair. Just a quick question. The 2 model states you spoke of, it was Arizona, and what was the other state?
Georgia.
Georgia. Thank you. Thank you, Madam Chair.
Delegate Lewis, you can take your hand down, and that's all the questions that I see. Again, thank you to the panel. We really appreciate your time and your briefing us on this so that we're kept up to date, and we'll look forward to hearing good news as time goes by.
Thank you for
Madam
having
Chair.
us.
Thank you. Bye-bye.
Bye-bye. Let's see, with that.
Just a reminder,
What
we'll
I
be joining the bill hearing on a separate Zoom link.
Right. Thanks for joining us for this committee briefing. We'll reconvene at 2 p.m., but maybe it'll be 10 after 2. Actually, try to get on close to 2, because there's always a lag time between when people get on and the meeting. So that would be good. And with that, we'll say the briefing is ended, and I'll see you in the hearing using a separate link very shortly.